Caroline van Vlaardingen. Welcome to In Search of Dopamine, a podcast series that brings together healthcare professionals, people with Parkinson's, and caregivers to explore the challenges and symptoms and live with the disease. My name is Caroline van Vlaardingen, and welcome to this episode of In Search of Dopamine. In Search of Dopamine is a podcast series produced by Parkinson Québec, and in each episode we look at a different symptom of the disease, and today we're going to look at hallucinations. Now, hallucinations occur in about 50% of patients, and they can be anxiety-producing, which is why we wanted to discuss them today to try to put people at ease a little bit about them. They can also sometimes have a bit of a stigma, so we'd like to address that as well. Joining me in studio today to discuss this is Dr. Philippe Huot. Dr. Huot is a movement disorder neurologist and scientist at the Montreal Neurological Institute right here in Montreal. Welcome, Dr. Huot.
Thank you for having me.
And Pascal Girard is a social worker, also working at the Movement and Disorder Clinic at McGill. Also works with Dr. Huot, sees some of the same patients. Thanks for being with us today, Pascal.
Thank you.
Okay, let's start with the basics. What are hallucinations, and are they any different from delusions? I'll start with you on this, Philippe, if you don't mind.
Thank you so much. So hallucinations, I guess, could be defined as a creation of the brain that is not really there. For instance, patients may see something that is not really there, and there's different degrees of hallucinations in which they can keep insight. That would be like hallucination, but sometimes they may think that the hallucinations are so real that they may be convinced that something is really happening, and they cannot be convinced or told otherwise. And this is what I would call a delusion, when there's like loss of this insight that the hallucinations are not real, and that there can be various degrees of the way or the severity of the delusion and of the loss of the insight. Briefly, that's how I would frame it.
And we said off the top that they occur in about 50% of patients. Does that sound right to you based on your clinical experience? About half your patients have had some experience with them?
Yes, but it also depends on the stage of the disease. Like 50% of patients in the more advanced stages of the disease, they're less common than that in the early stages. So I guess we could say that they occur in up to 50% of people, depending on the disease stages.
I should mention one thing here before we bring you into this discussion, Pascal. We did actually speak to a gentleman who was diagnosed with Parkinson's about, I think, 7-8 years ago. Now he's in his 70s, and he has experienced quite a few hallucinations, and he explained them to us or to me over the phone. And I'm going to work in some of his experiences into our discussion because he couldn't be here with us today. But I think his anecdotes will help shed light perhaps on how they can manifest and how you can deal with them. So I'll talk about a little bit about what he shared with us. But let's get to you now, Pascal. How do you, when someone walks into your clinic for help, how do you assess whether or not they've had hallucinations or are having them?
Well, often it's a discussion. As a social worker, I'm not the one really always going about every symptom, but we kind of normalize at the clinic, like there's the motor symptom, like the walking, the gait, the difficulty dressing up and things like that. But there's also the non-motor, which is a part that I discuss a lot with patients. Sometimes it could be like anxiety, depression, how they're doing. And then you go into cognitive, if they see or notice any cognitive change. And then if the discussion goes, we kind of go in that. Do you hear sometime or see something that is not there? Do other people tell you? But we kind of treat it like, we normalize it in a way that we discuss about them the same way we can discuss about tremor and other symptoms.
So you kind of just casually bring it in and ask, because as I said, there's a bit of anxiety about this. Understandably, if any of us were to see something that isn't really in the room or hear something, it would be stressful. So do you, when you say you normalize it, this is part of the disease, right? And so it's nothing to feel ashamed of.
Well, often when it's a new diagnosis, we don't always ask right away, but sometimes, we can provide literature and guide and thing, and people go on the internet, so they read about sometimes more advanced symptoms. Sometimes they're the one bringing it up, but we do kind of reassure that they're not the exception by having them. And there's a way to cope and treat them. So.
How do they manifest? Are they always visual, or can they be manifest in other ways?
So that's a good question. The majority of hallucinations in Parkinson's are visual hallucinations, but other types of hallucinations have also been described. Notably, auditory, olfactory, gustatory, tactile. Essentially,
gustatory is taste?
Yes.
Okay.
Essentially, all kind of any sensory modality may produce hallucinations, and sometimes people may experience what's called multimodal hallucinations, meaning that they will have visual plus something. And what we also know is that in the course of the disease, the hallucinations may fluctuate. Like some people may start by having visual, then they may have auditory, then they may have a combination of both, then they may have another modality that adds up to that. So it's very much in motion, but visual hallucinations are the most common type of hallucinations.
But so many varieties of ways that they can be expressed, as you say, with all the senses really being involved. And so you said the visuals are the more common ones. Is there a way to assess in the early stages who is more likely to get them?
Well, it's very hard to know that, although we've discussed a bit earlier. I don't know if it's a good time to bring RBD here, but
go ahead.
RBD is, as you know, maybe experience or REM sleep behavior
RBD?
Disorder. That's a good point. So it's when people have like very vivid dreams, and sometimes they wake up during their sleep, they yell, they move, they have lots of nightmares. So that's RBD. It can be associated with increased risk or occurrence of visual hallucinations. Apart from it, we know that there may be some genetic forms of Parkinson's disease that may be associated with an increased prevalence of visual hallucinations, but genetic forms of Parkinson's disease are not the majority of cases, and we will not necessarily screen patients that we see for genetic conditions unless we have a reason to do so. But still, and some people early on may have hallucinations before the motor manifestations of Parkinson's. But that's more in the realm of Lewy body dementia. So that's not really Parkinson's, although even that, based on some articles, is probably debatable as well, because some people may have hallucinations. It's reported now in probably the premotor phases of the disease. So I guess there are some ways that we can probably identify people more at risk of having hallucinations, but I would say that maybe not the majority of cases.
What is the basic science, though, behind hallucinations? What's going on in the brain that causes them?
So it's very complex. Parkinson's disease, for years, Parkinson's disease has been seen as a condition where there's not enough dopamine inside the brain. But what we know now is that because we treat our patients longer, they stay with us for longer time, they have better quality of life. So the disease evolves for longer, and the disease manifests itself through other ways, such as hallucinations and cognitive problems. And that's because there's other brain areas that are affected by the disease. And what we do know is that in the brain of people with Parkinson's, there's an abnormal protein that's called alpha-synuclein, and that forms clusters inside the cells that we call Lewy bodies. And when there are Lewy bodies deposits inside some of the areas involved in visual processing, for instance, the temporal lobe, that may be a risk factor, or that may predispose to have hallucinations. So this is something that we would see more in advanced disease. We also know that there are differences in brain metabolism and cerebral blood flow. So there have been some imaging studies that showed that in people with visual hallucinations, the metabolism may be altered in some areas and the blood flow is not what it should be. And then there's also like neurochemical changes that happen, and there's a neurotransmitter called serotonin, and a receptor of this neurotransmitter, the serotonin two-way receptor, that is upregulated, so meaning that there's more of it in some brain areas, especially the ones involved in visual processing. So if we summarize, we have more like Parkinson pathology, so more Lewy bodies, more serotonin receptors, altered blood flow, altered metabolism. So all that at some point culminates in the emergence or the manifestation of visual hallucinations, which is what I'm using as an example because it's the most frequent.
So a lot of different factors, a lot of different chemical things going on in the brain. Are there drugs that can mitigate these reactions and things? We talked about dopamine. You talked about Lewy body dementia. Are there drugs that can help to lower the incidence of hallucinations?
So we don't use drugs that would lower the dopamine transmission in Parkinson's because the treatment is with levodopa. So we're trying to give them more dopamine. Right. If we use dopamine blockers, we're going to reduce the beneficial effect of our drug. So we don't do it.
I didn't mean to lower dopamine. I meant to lower hallucinations. Yeah, the incidence or the chances of. Yes.
At the moment, not really. I mean, and that would probably bring us to a treatment that would be maybe disease modifying, or that would slow the progression of the disease, which is one of the holy grails in Parkinson's, really. But this is something that we don't have at the moment. Although there are some steps that can be taken, and I know we may talk about it later, but there are some risk factors that are modifiable. And one of them is like having good eyesight. So this is like, because this is a risk factor. So we know that people who don't see well, don't have good visual acuity, like for instance cataracts, may be at more risk of developing hallucinations. So I think last week I had a patient and I told them, well, you need to have your eyes checked because didn't see well, had hallucinations. Maybe by just getting the eyes fixed, we're going to solve the problem. Maybe not, but it's possible. So there are things that can be done, like make sure that people hear well as well. Make sure that there's no, I'm going to use a big scientific term, but no deafferentation, like the senses are working properly. That may help up to a point.
So really important to have the eyes checked, the hearing checked, to make sure that that is not causing or contributing to things that aren't real, that are being sort of perceived by the person.
Yes.
That's a good way to summarize that.
Absolutely.
Okay. And so you probably ask those questions too then, Pascal. You ask about, have your eyes been checked recently, that kind of thing?
We do, yeah. I mean, me, part of the team, we do, because sometimes the solution, or one of the solution, is it's simpler than adding another medication. We all had story like where someone like just need to adjust their hearing aid, or like he said, like getting your eye checked, and sometimes it does solve maybe not all, but a big percentage of the problem. Sometimes it's not always adding a medication. Sometimes it could be I'm not the doctor, but sometimes you question and then you look at things, and sometimes the solution might be lowering a medication too, which maybe Dr. Philippe could confirm or not. But so sometimes there's simple solution that can be put into place.
Since we're on the topic of medications, clozapine is a medication, I believe, that is prescribed sometimes for people who are anxious. Is that right? or suffering from delusions?
Delusions or hallucinations, anxiety, we treat probably with other categories of medication. But yeah, I mean, we can talk about treatments or the drugs. There is one drug that is approved by the FDA to treat hallucinations and Parkinson's. It's pimavanserin. We don't have it here in Canada, so I'm not going to talk about it too much. But it acts at the serotonin 2A receptors that we were talking about. Practically speaking, there's different ways to address that with drugs. Often, a first treatment is quetiapine. People may know it by Seroquel. It's an antipsychotic, but really, I don't like the term antipsychotic. I prefer the term multi-target drug. So it binds to a lot of stuff, and it helps alleviating hallucinations. We prescribe it, but the evidence is not overwhelming that it's going to work. Because there's been a bunch of trials that said it works, but others that said it doesn't work. But in comparison to clozapine, for which there's clear evidence that it works, it's safer. Because clozapine, a danger of clozapine is that it may reduce the white blood cells. We call that agranulocytosis. So we need to monitor the white blood cell count on a weekly basis for several weeks, then every 2 weeks for several weeks, and then once a month for life. But it does work. And I have a few patients on clozapine, and it also works for dyskinesias. And it also works for tremor. So it's a miraculous drug for Parkinson's, but it's associated with a side effect profile that is problematic. And a drug that I really like prescribing is rivastigmine. So it acts through another mechanism of action. It increases an enzyme, a neurotransmitter that's called acetylcholine, which is the neurotransmitter of the memory and of the cognition. So it may improve cognitive features, may help hallucinations, and there's increasing evidence that it's also good for the walking in people with Parkinson's. The problem with that is that we need to have people with cognitive impairment to prescribe it, because that's the indication, cognitive impairment and hallucinations in people with cognitive impairment in Parkinson's disease. But I do like it because we do address several issues with a single medication.
Okay, interesting. We've talked a lot about medications. Is there any kind of a link between some of the medications that are prescribed for people with Parkinson's and hallucinations? Do we know about that?
So this, again, is a complex question, and it depends on the studies that you're looking at. So there are some studies that say that there's no correlation between various anti-Parkinsonian medication like levodopa or Sinemet or Prolopa, the various dopamine agonists, entacapone, amantadine, the anticholinergics. But then you look at other studies, and they find that there may be a link between the intake of these medications and the occurrence of hallucinations. So practically speaking, what we do, we always try to reduce and, if possible, completely remove the agents that we know may be involved in hallucinations. And that would be the anticholinergics like cogentin, benstropine, artane, medications like that.
What are anticholinergics? Sorry.
It's medication that are good for tremor.
Okay.
So we don't prescribe them very much anymore, but they still have a use in people with severe tremor. Amantadine, which is primarily used for dyskinesias, and the dopamine agonists, which are used essentially as anti-Parkinsonian agents. So we do try to reduce them, as well as the entacapone, until we reach a point where the patients are good from a motor anti-Parkinsonian perspective, and they're also good in terms of hallucinations. And when it's not possible, or when we feel that if we reduce further, we're going to make the patients uncomfortable, then we can consider adding a treatment, which is usually what I try to do. But sometimes patients, when they have fluctuations and when motor-wise it's difficult to reduce the medication without making them feel bad, then we add an agent such as the ones that we talked about earlier.
The person we spoke with who allowed us to share his stories, he has talked about having some very scary and vivid hallucinations. And he thinks that it could be related to dreaming, as we talked about earlier, because he's always been a very big dreamer. Can you go back to the subject of rapid eye movement disorder and dreaming and hallucinations again? I mean, do we know if there's a link there?
Yes. So there is a link, and it's an independent risk factor for the occurrence of hallucinations in Parkinson's disease, the presence of REM sleep behavior disorder, which is essentially, I'm going to explain you what REM sleep behavior disorder is, but very rapidly. So normally, there's different stages of sleep. There's the light sleep, there's the deep sleep, and there's the REM sleep, REM for rapid eye movement. Normally, during rapid eye movement sleep, we're unable to move. We're paralyzed. But people with Parkinson's, because of the changes that occur inside the brain, they're not paralyzed during REM sleep, so they're able to move, and often they enact their dreams. And they may remember some of these dreams, and these dreams may be, in some instances, very vivid, disturbing. Sometimes they may be pleasant. We have some patients telling us that they're pleasant. Others are telling us that they're nightmares, completely scary. So we need to see what they are. And we may treat them if they're scary, if they punch the bed partner, for instance, or if they fall off bed because they're enacting a dream. There's a danger. So we need to address the RBD. We don't address it with the same medication that we would treat hallucinations with. And I think it's important to differentiate that hallucinations occur in the awake state, whereas REM sleep behavior disorder, by definition, occurs during sleep. And I would also like to point out that some of my patients who I thought had REM sleep behavior disorder had other sleep-related issues without REM sleep behavior disorder, notably sleep apnea. And I mean, sleep apnea is a condition in which there's a bunch of micro awakenings. So patients dream and they remember their dreams, but they don't get into the deep sleep, which is why they remember their dreams. But it's not the same thing as rapid eye movement sleep disorder necessarily. So that can be diagnosed with a polysomnography. That's how we would diagnose it. And the treatment would differ between the two conditions.
That would be like a breathing obstruction or something else that's causing that.
That's it.
So is that being done routinely with people who are complaining about hallucinations? Are they being checked for sleep apnea or any of those other things as well?
At our clinic, yes. I think this is pretty common. I don't know if it is everywhere, but I guess if people are aware, they can maybe ask or question. But yeah, it's often something that it's rule out, before going.
Pascal, let's talk a little bit about the people that you see. What kind of impacts have they told you that these hallucinations have had on their lives? So how are they experiencing them and dealing with them?
Well, I think one of the interesting things with my position is and Philippe too, we work with people for many years, So sometime when these hallucination offers disclose or cure, there's a lot of sometime, people are more, they could be scary or it could be worrisome. And am I losing my mind? People will ask you those things. And sometimes there's a lot of education to say that no, it doesn't always mean that, it could be, and those could be treated, and there's a lot of education about identifying if the hallucination are bothersome or not, because sometimes we don't talk about that, but for a lot of people, they can be pleasant too. They can be they learn to live with it. But when I say that, the advantages to be working with people for a long time is you see people learning to cope and sometimes live with the hallucination. And yeah, so there's people, it happens fairly often that there's people that joke about the hallucination or put name to the cat they see.
Yeah, that's exactly what our gentleman told us, that he often sees a little cat and he has sort of seen that cat as a friendly creature, and he, says, "Come on, let's go for a walk now. Oh, you want to join with me? You want to come with me to do this? Okay, that's fine." He's also seen little children,
Mhm.
toddlers around him, and he finds that comforting as well.
Yeah.
And he has shared this with his partner, his wife, and his family members, so that they know that if he's suddenly paying attention to a body that is not in the room, that they are also not freaked out, and that they can sort of just accept it and say, "Oh, okay, your friend is back." Is that a good idea?
It is, I think, and it's also interesting because it is hard to sometimes understand when you're not in it. You
Mhm.
see that, but the more we work with people that learn to live with this hallucination, you kind of see that there can be a pattern where people in the family can learn to live with the hallucination if they're not bothersome again,
Mhm.
and even joke about it. It's the same way that some people with Parkinson can learn to live with some other symptoms that are different. But and with time, people are able sometimes to develop trick or identify if it's a real cat or an hallucination. So sometimes you get people that can say they close their eye and then they reopen if it's there. Some people are able to identify because it's visually
Is
different.
that a good idea to close your eyes for a while
I
and just
They
see if
can
it
try. I
passes?
think people can try it
Mhm.
and see. I know some people use that. What worked for someone don't always work for someone else. Some people ask their spouse or family uh, if there's something there. Because if you also bring the people around you and you don't keep that for yourself, and you
It
and
can be anxiety producing too
yeah,
if you're
that could
trying
be
to hide
scary if
it,
you see
right,
there's a
from
dog
others?
here
Yeah.
and the person, or there's someone here and the
Yeah.
person panic too, and then it come and it's so
Feeds on
so
itself.
so at
Yeah.
first you can have that, but with time you see sometime medication, but sometime learning how to cope with it, you see that it kind of people learn to sometime cope, live with it.
Our patient actually shared something that he does, which I thought was really interesting. I want to get your reaction to
Hmm.
this. He will sometimes, if he feels that there's a hallucination coming on, he'll take a moment to look at his watch or a clock, and he'll actually time how long it is taking place, so that he kind of has a sense, okay, time is passing and this thing is here for a minute or two. Like, he'll clock
Hmm.
it. And that way he sort of feels like, okay, it's going to end at some point so that I can get back to my activities or doing what I want. So he's sort of keeping track of them and not getting too worried.
Yeah, so I'm not surprised. There's people that will say that. Some people, when they got hallucination, not everybody, but some people would say that's mean I'm tired and it's time to go to bed, or to take.
Mm.
Some people will like the lighting. If the lighting is too
Dim.
dim, there's
Hmm.
shadow and thing, then that can be like all those things can be looked at. And
Triggers. And you mentioned, I'm too tired, I should go to bed. Is fatigue a trigger for hallucinations if you're tired?
I mean, I think you got me on that one. I mean, I guess sometimes you may have, yes, I mean, people
Because
may
fatigue is
have,
such a huge part of the disease, right? It's
yeah,
so, yeah.
yeah. So, and sometimes when you fall asleep, you may have like those, like, but it's almost like a dreamy phenomenon at this stage. So, it may be a bit difficult to really know what's going on, because sometimes when you just fall asleep, you're just like thinking about something. When you're dozing off, are you hallucinating, or are you just like dreaming and you remember your dreams? So I guess, and we have some patients, they tell us that when they fall asleep, and I'm always reluctant to call it a hallucination, because it's not clear to me that it's not like the early manifestations of a dream, or if it's not a proper hallucination per se.
Mm.
And they don't know if they're fully awake or not. So it's I guess it's a gray area.
Hmm. Pascal, do you have any thoughts on that?
not on that. It's more when I say someone said that they need to go to bed, they're tired, is because sometimes other symptoms flare up too.
Hmm.
Some people say some people have more. It depends. Some people have pattern. It's a illness of routines for some people, and some people would be like these symptoms will happen more in the evening. You ask, are they happening in the morning, evening, afternoon? When you so that was one example of someone that said more like that.
Hmm. How should family members and caregivers react to hallucinations? Is there a right way and a wrong way?
It's not really a wrong way, but there's a way that can ease, let's say, the person who have the hallucination, because let's say the hallucination are scary or bothersome or put the person in distress. Well, one of the thing is maybe to reassure more than to confront, because the first reaction would be like, no, there's nothing, and and that if the person see it sometime and is not able to kind of realize that they're not there, well, that can make the emotion even bigger and even like worse. So uh, but it is hard, with time people learn to sometimes reassure and not always confront, but sometimes change the subject, or you reassure, you said we're okay, and then we see sometimes people changing the subject, or you change a room, but you don't confront in a way that no, it's not there, or there's nothing, or because that could be the first reaction. And sometimes we see it at the hospital. I see people hallucinating, or they have it at the hospital, and they see the other person just reassuring them, no, you're okay, and I'm there. And
So basically
then,
making them feel safe
yeah,
is the important thing
yeah,
here,
because
not arguing. Yeah.
if the person, the emotion are elevated, and if the spouse or caregiver or the person with kind of match the same level, well, that will keep going up. So if you stay calm, and then that will sometime naturally bring the emotion down.
Very important. Thank you for that, Pascal. Caregivers are so much a part of how a person can live with Parkinson's. What are the impacts on caregivers of hallucinations? Because we've heard that people have jumped out of bed at times or struck the person lying next to them.
Yeah, this is it. It is sometimes it is the hallucination could affect as much sometimes from what I see, the caregiver than the person who has the hallucination, because often, like other symptom of the Parkinson, well, that's one more that they have to learn to cope and live with too, like the person. But again, I think when we meet people, and if we provide education to both the caregiver and the person, and often you see caregiver become expert of the I'm sure a lot of people watch that, they way more expert than us
They
in
know a
some
lot out
way.
of necessity.
Yeah, sometimes we ask them, we say, what do you do when most of the time we say, what do you do when these occur? And then some of them have developed their own method, that because if they're a unit or a family or a couple, they sometimes have their own way to deal with anything in life. And that's the same with hallucination. But you see people going sometimes to a period of there's grief associated with that too, because sometimes those can be, they could be a loss of quality of life for them too. But again, that's the beauty of it sometime. And maybe I say too much because that's not for everybody, but some will learn to make light of them together as a couple too. We see that. So, and those stories to me give hope for the people who have the disease, the caregiver, the spouse, and also us working with people with Parkinson. When you see that, like, yes, there's treatment. It's always going to be about medication, a lot of it, but there's also how you adapt and learn to restructure your life around them. But again, often it become part of their normal life. Once they learn how to often react, if they got a team that they trust and think, well, they will often adapt and then learn to live with it, which is easy to say, but I see that with time, people.
A lot of courage. There's a lot of courage out there. We talked about visual issues, hearing. What about diet, alcohol? Can they play a role in hallucinations?
I mean, again, that's a good question. I guess alcohol, when consumed in moderation, is probably okay. But too much alcohol is certainly not a good thing. Even for hallucinations and for the brain in general, it's not advisable to
for
have
any of us,
alcohol. So in that sense, it's probably not not the best. Some drugs are probably not the best either. Like we do have people doing drugs. That's not advisable either. When it comes to diet, I mean, I can't think of any specific diet like Mediterranean diet or anything that would be more likely to cause hallucinations. Sometimes some beverages, like highly caffeinated beverages, may cause anxiety and palpitations. So, and sometimes when people are anxious, they can kind of think that they're going to hallucinate just because of the anxiety. So, in a sense, I guess it could be possible, but that's probably a bit far-fetched.
Okay. So the odd glass of wine is not going to really put you at more risk of hallucinations.
No, and if it makes people happy, then why not?
Yeah. Brings down the anxiety a little bit.
I think so, I guess.
Speaking of anxiety, are sometimes patients reluctant to talk about this at all because they're worried that it could, change their independence, that you could recommend something for them that they're not ready to accept yet?
I'm sure there's some subject. Parkinson it's really broad, in the symptom, all the symptom that can occur. I am sure it's very difficult to disclose because that might be there's also the fear of how it can progress, but also that could be like, do I have to stop driving if I got hallucination? All that, as a social worker, we can discuss that and process, because there's some loss and grief, and that doesn't mean they will have to stop driving. But, this is a worrisome thing, like some other symptom. And often as Parkinson progress, it's almost impossible to not go into those questions about, let's say, driving, because that could be one. But if you don't disclose and it's a bothersome symptom and it's bringing anxiety, then your quality of life will go down too. So I would encourage people to disclose, because sometimes the solution can be simple too. Sometime by treating other symptom, then you can, there could be side effect and things that could elevate it some. So all those things could be looked at, and I don't know, for the overall quality of life, I think there should be, but you have to trust also the team with who you work.
And going out in public must be a bit of a concern too, because if you can't really anticipate when a hallucination is going to happen, and you're in a crowd of strangers, not people who know that you have Parkinson's, but people who don't know, that must be anxiety provoking to a certain extent. Do you have any advice on that?
That's what we're aiming to do with our patients. I mean, we're trying to get them to live a life as normal as possible, which is why we encourage them to tell us, because if they don't tell us, we cannot help them. I find that sometimes what may be helpful is to be with someone. And very often, but not all the time, when patients have hallucinations, they do come with a caregiver. So if they don't mention it, the caregiver often mentions it. And then I was like, oh, you didn't tell me that. Not necessarily because they don't want to, but sometimes they don't want to because they're afraid that they're going to be judged. But I always try to emphasize that this is a safe space and that they need to tell me. But to go, for instance, like going out, I mean, this could be an issue, especially if the hallucinations are bothersome or frightening. But then there are medications that we can also give to lower the anxiety. But that would be another category of medication that we would prescribe to the patients.
And we know that isolation is not good for people with Parkinson's, right? That can make it worse. So we don't want to, encourage people to stay at home and just wait for the next hallucination.
And I think some of those discussion and like everything that is done by Parkinson Québec and others to kind of like educate the population about Parkinson, because often what I see what we see at the clinic, we see people, yes, that isolate because the Parkinson can have the symptom that you're more tired and like the mobility and other thing and the hallucination, but also because there could be some stigma associated with the disease, and people, it's a disease that's often, I see people in the clinic that's often associated with a lot of sometimes shame, not for everybody, but some people use those words, with me, and and then you see different way of coping with it. Some people isolate more, and or they do thing with like a more regular people, less a smaller group of people. But you also see some other people, like I said, we see the whole spectrum of people who sometimes learn to just sometimes laugh at the hallucination, and then they're the one explaining to people, this is a symptom, I have that, and they normalize to other people too. So, and sometimes we relay those stories to the other one, or we match them together to kind of find a middle ground where the person will not, their quality of life will not, could be improved by, I don't know, doing what they love and continue living even with the.
I'm wondering, is there any kind of a service for, I know Parkinson Québec has a website, very active website, and they have numbers to call for people. What if someone's living alone and they have a hallucination? Is there a place they can call and say, I'm having this right now and I'm a bit nervous about this? Is there anything like that, sort of a helpline?
Well, I'm not sure. Well, it depends on the clinic where you follow.
Yeah.
Us, people call us.
I was going to say,
there's
do you have
there's
like a
nurse.
helpline? Yeah.
Well, there's a nurse you can always call at our clinic. I know it's not always the case for everybody, so that's why I think when you see your doctor, your neurologist, that's the only person on your team, you have your list of questions. I think it's important to talk about it. Then I know that people will watch that go online. So there's different association that could be Parkinson Québec or other that I don't know if I can name, but yes, if you Google that, they could be
a lot of resources out there to
yeah.
sort of maybe put you at ease and to sort of calm you down in those situations.
And like every disease, and because it's a chronic disease, you can find a way to people learn to live with it, but they find by going to support group and thing, then if they share with someone with similar experience, might not apply to them, but they could find a little trick here and there, or something that they can then share and come. So
I think you hit it on the nose when you said normalizing, so that it doesn't feel like it's something that's just happening to you, and that it is something that you can deal with through medication, through little tricks to calm yourself down in those situations, and obviously your circle of support as well, to also not overreact to it, would you say?
And I guess that what you said is very important. We could say you are not alone. We follow many people with hallucinations and we're able to help them.
And some people will have them, and doesn't mean, because it's a chronic disease again, and the progression is there's a progression, but it's slow. Sometimes people could be at the same stage, in a sense, the same level of symptom for a long time. It is worrisome, and that's easy for me to say. But I do see people to those years where you ask, are the hallucination worse, or are they? And no, and sometimes it is not the thing that is. When they come to the doctor, sometimes the hallucination is not on their list of things that they want to talk about. There's, I don't know, constipation, other thing that could be, that's my problem. The hallucination, I live with this cat, like this. Let's say this cat is there, been there for many years.
I've given him a name.
I've not increased. That happened too,
Yeah.
But it's so true. Like sometimes I have to ask my patients. So last time I saw you, you talked about your hallucinations. You still have them? How's it going with the hallucinations? And they say, "Oh yeah, that's true. Yes."
I forgot I had them. Yeah.
We see that, and it is common too. It's not always the case, but we see that people where this is not the problem. The problem is something else for me. So that's where it is.
So interesting. Well, we cannot conclude this discussion without letting you know at home that there are so many resources out there for you. The Parkinson Québec website is full of information and activities that can help you and your loved ones to deal with Parkinson. And also a reminder that Parkinson Québec and its partners are continuously developing new tools and new resources to better serve you. You can consult the Parkinson Québec website at parkinsonquebec.ca, and they have plenty of information on their social media sites as well. I'd like to conclude by thanking our guest today, Dr. Philippe Huot, movement disorder neurologist and scientist at the Montreal Neurological Institute. Thank you so much for coming in today, Philippe. And Pascal Girard, social worker, working at McGill as well in the movement and disorder clinic.
Thank you.
Thank you so much, both of you. I also want to thank the person who spoke to me at length about his hallucinations and symptoms. It was invaluable information, and we wish him and his family well as well. Thank you so much for opening up to us so that we can share your story with other people and hopefully make them feel a little less alone in this. Well, that concludes this episode of the podcast series In Search of Dopamine. The series is made possible by a grant from the Quebec government under its program Québec Amis des Aînés. My name is Caroline van Vlaardingen. You can find more episodes of the podcast series In Search of Dopamine in both French and English on the Parkinson Québec website and on places where you find your favorite podcasts. Thanks so much for joining us, and we'll see you again soon. Take care.